In the management of thromboembolic disorders, the pharmacological landscape has shifted significantly from the traditional use of warfarin, a vitamin K antagonist, to direct oral anticoagulants, DOACs. The primary difference lies in their precision. Warfarin acts like a shotgun, broadly suppressing the synthesis of multiple clotting factors, whereas DOACs act like a sniper, targeting a single specific protein in the coagulation cascade. The most fundamental difference is how these drugs prevent clot formation. Warfarin is indirect. It is a vitamin K antagonist which inhibits the key enzyme vitamin K epoxide reductase. This prevents the liver from synthesizing functional factor 2, factor 7, factor 9 and 10, as well as the anticoagulant proteins C and S. DOACs are directly acting. These drugs bypass the synthesis stage and bind directly to active clotting factors already present in the blood. Direct thrombin inhibitors like dabigatran binds to factor 2A thrombin. Factor 10A inhibitors like rivaroxaban, apixaban and edoxaban bind to factor 10A. DOACs were designed primarily to address the unpredictable nature of warfarin therapy. Warfarin has slow onset of action, 3 to 5 days to reach therapeutic levels, while DOACs are rapidly acting with 1 to 4 hours for peak effect. Offset of action is also long, several days for warfarin, while it is short, 12 to 24 hours for DOACs. Dosing is variable and requires frequent adjustment in case of warfarin, while DOACs have a fixed dosing. Monitoring is required like PT-INR blood tests for warfarin, while not required routinely for DOACs. There is extensive interaction with food and medications and vitamin K intake in foods for warfarin, while interactions are minimal for DOACs. Half-life is long, approximately 40 hours for warfarin, while it is short, 7 to 15 hours for DOACs. While DOACs are often preferred for convenience, they are not universally superior. There are situations where warfarin still wins. In case of mechanical heart valves, warfarin remains the gold standard. DOACs, specifically dabigatran, was found to be inferior and potentially dangerous in patients with mechanical valves. In severe renal failure, warfarin has an edge over. Warfarin is metabolized primarily by the liver, making it safer for patients with end-stage renal disease (ESRD). DOACs rely on renal clearance to varying degrees, dabigatran being the most renal dependent. In this context, it is worth noting that warfarin use is strongly associated with accelerating and increasing arterial calcification, including in coronary and peripheral arteries. That is by inhibiting matrix glycoprotein MGP, a natural inhibitor of calcium buildup leading to potential cardiovascular complications. Warfarin is significantly less expensive, though the cost of frequent INR monitoring can offset this to some extent. Here are the situations where DOACs excel. DOACs generally show a lower risk of intracranial hemorrhage compared to warfarin. And lifestyle is better. No restriction on green leafy vegetables, and there is no need for monthly clinic visits for drawing blood and checking prothrombin time with INR. Regarding reversibility, warfarin was preferred because its effects could be reversed quickly in case of toxicity with vitamin K or prothrombin complex concentrate. But today, specific antidotes do exist for DOACs, though not widely available and quite expensive. Idarucizumab reverses dabigatran, and andixanet alpha can reverse factor Xa inhibitors like apixaban and rivaroxaban. To summarize, you can choose DOACs for their convenience, lower risk of intracranial hemorrhage, and in cases of non-valvular atrial fibrillation. Warfarin is chosen for mechanical heart valves, in those with severe kidney disease, or when cost is a primary concern.